Ladies and gentlemen, next we have a plenary on a very timely topic, global impact of COVID-19 on maternal and newborn health. To chair this session, let me cordially invite Dr. Nihal Abesinghe, Consultant Community Physician and the President of College of Community Physicians of Sri Lanka, and Dr. Kaushalya Kasuvirarachi, the President of the Perinatal Society of Sri Lanka, to please come on stage.
Good morning. Thank you very much for joining this session on global impact of COVID-19 on maternal and newborn health. Very important topic, and we see that a lot of issues are coming up even within Sri Lanka, that on the antenatal, natal, postnatal and newborn health services in the country. So let me first invite Dr. Rasia Pense, WHO representative to country to Sri Lanka, to join us for this session. Okay. Thank you very much, Razia, joining us. And then, so let me introduce Dr. Rasia Pense, the speaker today. And Dr. Rasia Pense took over as WHO representative to Sri Lanka in May 2017. Received her Doctor of Medicine in Pediatrics from the University of Rajasthan, India, and Masters in Public Health MPH from the University of London, UK. She has more than 15 years of experience working in public health. She previously served as the Assistant Project Officer, Safe Motherhood and Newborn Care, UNICEF India, and has done consultancies for UNFPA and started the public health career working for non-governmental organization. And I had the pleasure to work with her at WHO CRO. We were regional advisors for different subjects. So over to Rasia for you.
Thank you, Dr. Abesinghe. Good morning, everyone. Let me thank the organizers for inviting WHO for this important session. And in a year that has been unprecedented, a pandemic of our lifetimes that has disrupted lives and livelihoods, while we chase the virus and try to be ahead of the virus, one of the important collateral damages that has happened is disruption in essential services because of the lockdowns that were necessitated to control and break the chains of transmission. Within the essential services, the services for maternal newborn child health were the most impacted, and today we will just go through what were few of these impacts, what we should do, and what WHO can do to help countries ensure resumption of essential services, continuity of these services during the times of crisis, and what are some of the lessons learned for the future. This is just a quote from the WHO Director General, Dr. Tedros. And basically, what he's saying is that a once in a lifetime or once in a century pandemic that has hammered home a critical lesson. When it comes to health, our destinies are intertwined. This is the dashboard I took last evening, and it's not just to look at the numbers. We are over 70 million cases globally, over 1.6 million deaths. The pandemic has left no country untouched. It's a bubble graph, and you'll see that the bubbles are there in most parts of the world. The size is the size of the epidemic in those countries. Women and children have been impacted throughout the lifetimes of the Homo sapiens, because pandemics, it's not the first pandemic, it's not the last pandemic. Epidemics and pandemics have happened throughout, and if we were just to trace this century, there have been different pandemics, some classified as pandemics, some were epidemics restricted to a few countries. However, all of these have had their impact on women and children, some directly, some indirectly. Directly, like is the case of Zika and H1N1, and indirectly, like the others. In terms of the COVID-19 pandemic, one would ask the question, why maternal and child health? We haven't heard so much of the impact in terms of children, in terms of women. Most of the time, when it comes to pandemic and who are the vulnerable populations, we hear about the elderly, those over 60, those with comorbidities, and generally women and children fall through the cracks. Because over 60, women are outside the reproductive age. Children, there's not much impact. However, there has been both direct as well as indirect impacts of the pandemic, both in terms of morbidity, mortality, that is the health outcomes, and also the socioeconomic outcomes, which tend to impact women and children more. In the terms of the lockdowns, when there was restricted movement, we have seen increased instances of violence, both for women and children. And it's important to note that we have to measure what is the impact and do the course correction, record the lessons learned, because the indicators that have seen a setback because of the pandemic, and sometimes because of the response of the pandemic, when these population groups were left out, these indicators take a very long time to come back. So there is actually a regression while we are talking of progress. It's too early. It's 1 year since the new virus was known. We are yet to celebrate 1 year. We are yet to commemorate 1 year of the declaration of the public health emergency of international concern. It's too early to actually measure the impact on mortality, and partly it's also because of the disruption in measuring and monitoring mortality data aside of COVID. So the non-COVID mortality has not yet been measured and analyzed. If that happens, we will see the impact. The studies are ongoing. There are some country-specific studies which have shown the impact on the outcomes of pregnancy. For example, the study from the UK on stillbirths has actually shown that there has been increased stillbirth during the pandemic, during the lockdowns, or because of impact on access to services, or because of the fear of accessing services due to the fear of contracting a virus which was new. Initially, very little was known. There was a lot of public fear, and it's very difficult for people to make a choice. What is better, staying at home and not accessing care, or going to the hospital or the health care and risking contracting a new virus, the consequences of which are not known. There was also repurposing of staff in hospitals to take care of the pandemic, because it was quite a sudden shock to health systems, and it has actually brought down to their knees even the best health systems, the so-called best systems in the world. So there are some indicators or some information on the impact on morbidity. For example, rates of admissions to the intensive care unit because of non-COVID. Preterm births, we know that stress and other extraneous factors do impact preterm births in women, besides other medical and comorbid conditions. Admissions to the neonatal unit, stress in the mother impacts the newborn or the fetus, because the two are a dyad and one cannot be differentiated from the other. We do not as yet know the impact on mother-to-child transmission. As I said, we are still into the early days in terms of understanding the new virus. The science is still evolving. But if we look at the overall picture of what has happened to the essential services because of the disruptions of the pandemic, one in responding to the pandemic within the health system, and the non-health interventions that were put in place to prevent the chains of transmission, largely the lockdowns to restrict movement of people. So it had an impact on availability of healthcare workers, availability of services. It also reduced demand for services, one because people could not travel, the other they did not want to travel, and there were other factors because of the socioeconomic impact, because of lost livelihoods, and these impacted people at the margins the most. So actually it increased the vulnerabilities of the most vulnerable. So in a nutshell, there was a reduction in coverage of essential services, and some of the initial indicators that we are looking at, which is a very sensitive indicator, that is wasting in children, and that has actually seen an increase. This is just another way of looking at the factors which has been affected. If we look at it, both supply as well as demand side were impacted. And as I said, women and children, they suffer the most, both health as well as the socioeconomic consequences, when there is a restriction in movement and a restriction in access to services, because in most parts of the world, it's not the freedom of movement and access to various services doesn't come easy for mothers and hence for children. This is some of the data. So during May, June, and early July, there was a WHO global survey done on disruption of essential services, because very early on in the pandemic, it became known that the essential services were getting impacted, and the non-COVID services were actually bearing the largest toll of the pandemic because of the repurposing and because of the full attention of most of the health services and the governments on tackling the pandemic. And you would see that most of the indicators, be it outpatients or community-based care or inpatient or mobile services, these are some of the services which are accessed by women and children, and we see the disruptions in the range of over 50%. So this is the impact that it had. This is global data. And if you look at disruptions in reproductive, maternal, newborn, and child health services, right from family planning, antenatal care, facility-level births, routine immunization, in many countries, was just stopped, and we stand to face an increase in infant mortality because of disruptions in immunizations, and it will take multiple years to get the immunization services back on track. This is again the different reasons that were given by countries. This was a survey that was sent to the countries, and the countries responded to various questions. It's a busy slide, I would not go into it, but basically major reasons were repurposing of staff to take care of the pandemic, and though some of the services were disrupted because not enough healthcare workers were available to run those services, and in some instances the services were stopped because people had stopped accessing those services, so there were not enough footfall to continue those services. If we look at closer to the Southeast Asia region, this is just a dashboard, again, on different services. It's a busy slide. What I'm trying to show here is that the two countries which had the minimal disruptions, Bhutan and Democratic Republic of Korea, the two countries, DPRK has not yet reported a single case of COVID-19, local case, and Bhutan had very few. They were all importations. In rest of the countries, we'd see mostly it's yellow, that there was some disruptions, and there are some red boxes coming up that was complete. There was a significant disruption in essential services, and these include services for maternal, newborn, and child health. And again, the cause, this is for the countries of the Southeast Asia region, and some of the reasons, as for example, outpatients care was stopped because people were not coming. That was the fear, and I think so it boils down to effective risk communication. People were afraid to access care and put themselves and their loved ones in harm's way because of a poor understanding of what the pandemic was initially, because we did not know that much about the virus as we know now. Based on some of these findings in the low and middle income countries, a modeling study was done that what would be the impact of these disruption of essential services on maternal and child outcomes. So one of the reasons is health, but also disruption in food systems. As I said, access to as basic a necessity as food has been impacted and impacted massively. So from the pandemic of COVID-19, what is staring us into the face is a pandemic of hunger worldwide. The services had been disrupted, and it's important that these interventions are part of the response, because most of the time, these services are disrupted, and the mechanism for redressal is, okay, once the pandemic gets over, we are able to contain the spread of the virus, we will resume those services. So that is the mitigation model. But what we have lost in that time will take a very long time to recover. So it's important to ensure continuity of essential services throughout the pandemic response. And this actually makes us realize the importance of having resilient and sustainable health systems. That's a major lesson learned from the pandemic. No single country in the world was prepared enough for a pandemic. All of us knew that there is a pandemic, there will be a pandemic that is going to come, there will be pandemics in the future. The question is not if, the question is when, and when it comes, we have to be better prepared to serve our people and ensure the services that they need. And as I said, wasting, a very sensitive indicator for health of children, and we have seen that the wasting that has been unleashed because of the pandemic side effects could account for almost 20% of additional child deaths. Children, they are less likely to get sick or severely ill, and they are less likely to spread it. But they will bear the major burden of the pandemic because of loss of schooling and stunted social development because of lockdowns, and their increased risk of death because of disruption of essential services, as I mentioned, immunization, growth monitoring, access to nutritious food. These are some of the few essential services to children that have been disrupted. Upstream, family planning, access to contraception. There have been many packages that have been made on ensuring reproductive health services during emergencies. And I remember during the tsunami, there was a whole module made on how do you ensure reproductive, maternal, newborn, child health services during crises. Because crisis after crisis, what we have understood is access to contraception and family planning services is the most needed. That's the want of women. But these are the services that are not in the list of priorities. So it's extremely important that we take this to heart and ensure that every emergency response includes family planning and services for reproductive health services for women, because the outcomes of these are unintended pregnancies, which are not good for the health of either women or children, and the collateral damage is increase in abortions most of the time because of the socioeconomic distress. Good morning, Honorable Minister. I would continue. So these are some of the collateral damages that happen to women during emergencies. As I had mentioned before, what stares us in the face is a pandemic of hunger, and the World Food Program has estimated that 265 million people in lower and middle income countries face acute food insecurity, and the world needs to take account of this and set up measures. Otherwise, we would be setting the wheels in motion in the wrong direction. The UNICEF study has shown a 30% reduction in essential nutrition service coverage and 75 to 100% in areas of lockdown. As we see a resurgence in the pandemic in many parts of the world, lockdowns are actually increasing. So while we were looking at exit, we are actually moving into lockdowns in many parts of the world. And as I said, we are looking at additional child deaths due to wasting. Even in steady times, there is a gendered impact of services. Crisis only exacerbates these outcomes. And again, we do not have enough data, but whatever is available, we know that the impacts of the COVID-19 have been more acute, more harsh for women. And add to it, most of the health workforce in the front lines, the nurses, the midwives, the frontline functionaries, majority of them are women. And all of you would remember the pictures that were circulated on social media of mothers not able to see their children because of fear of taking the infection back home, the stress that they had to endure, the long hours of duty. And it's high time to value the role that women play as active participants in the pandemic response. While most of the COVID-19 decision-making meetings, how many women are on the panel? Next time you look at it, please look for women in those panels. They will be few and far in between. The shadow pandemic that has been unleashed, that is of violence against women and girls. And we have seen, and there is initial data available, that there has been increased instances of gender-based violence because of lockdowns and because of other socioeconomic distresses. So women have borne the brunt and a major share of the brunt of the pandemic and its outcomes. Moving to some of the actions, it's important to have a governance mechanism for reproductive, maternal, newborn, child, and adolescent health. There's a lot of talk on integrating our MNCH services. These are very important services. These are a reflection on how strong the health systems are or what priority governments put to the lives of women, children, and families and individuals. But we need to walk the talk. As I said, it's not an afterthought. It has to be part of the DNA of the response in steady state and, more importantly, in crisis. There has to be a technical working group advising the committees on the pandemic response on ensuring that essential services for reproductive, maternal, newborn, child health, as well as adolescent health are included within the package. And this has to be part of a preparedness plan so that you do not try to then pick up the nuts and bolts once the crisis has started. Identifying a core set of interventions with a core set of monitoring indicators would be extremely important, because when we do a before and after of the response, this should be the framework, the benchmarking, the standard against which you would measure your response. There has to be effective systems of delivery of non-COVID interventions, and we are still not out of the pandemic. The pandemic is still with us. Even though the vaccine news everybody is celebrating, it will be a while before vaccination is available, and we do not yet know what will be the duration of protection of the vaccine. So there will be those, bursts of cases that will keep on coming, including in Sri Lanka, and we have to ensure that the essential services continue to be delivered and mechanisms are in place for continuity of these services. Quickly moving to the role of WHO, of course, as the lead global health agency, we have been at the forefront of the response right from the beginning. There's multiple guidance that has been rolled out. There has been major work done to ensure that people get access to evidence-based information and guidance. Very early on, WHO came up with the guidance on operational planning to support country preparedness and response for COVID-19. Initially, it had 8 pillars, which were largely for the pandemic response. A 9th pillar on essential services were added early on. And some of the actions that WHO has taken since the beginning of the pandemic were to contain spread, ensure care of patients, and effective communication, and in a coordinated way across all 3 levels, bringing all the partners together. And there has been a lot of work done on engaging various social media platforms to address the infodemic, because the other typical thing about this pandemic, it is the first pandemic in the age of social media. There has been multiple guidance specifically to maternal and child health that has been published in the context of the COVID-19 for countries to access and make use of. For the infodemic, there's actually a whole EpiWin, and there's multiple resources, including videos explaining the science and busting the myths that's available. Just type WHO, and it will take you to who.int. The red box is that of the coronavirus disease. You click that, and you will reach the site with all the information. There has been multiple courses that has been developed for capacity building, especially of the healthcare providers. And these are open access. This is open WHO. You can enroll into any of these courses, and if you would, should you desire, peruse these resources. These are evidence-based and open access. Just one slide in terms of the access to affordable vaccine. All of you would have heard about the COVAX facility with the objective of ending the acute phase of the COVID-19 pandemic by the end of 2021, targeting 2 billion doses to be available to low and middle income countries by the end of 2021. This is an unprecedented collaboration and partnership to ensure equitable access to vaccine. And the 92 AMC countries will be getting 20% of the population coverage. These will be donor-funded doses. And first time, WHO has embarked on a solidarity trial, a multi-country trial on vaccine. Should you need more information, please log on to who.int. Closer home in Sri Lanka, the WHO country office, we have been engaged in all parts of the pandemic response in the country across all the 9 pillars of the Sri Lanka preparedness and response plan. And we have been able to work together with the Ministry of Health, and we would continue to work with the Ministry of Health, with the stakeholders, in ensuring that we are able to be ahead of the virus, to break the chains of transmission and save lives and preserve livelihoods, because a socioeconomic recovery for the pandemic is as important as health, but public health intervention are the path to socioeconomic recovery, and we have to ensure that we ensure safety while we are opening up the economy. Thank you very much. This is my ode to all the healthcare workers, the frontline functionaries of the COVID-19 pandemic. Thank you very much.
Thank you very much, Dr. Pense, for that very informative and timely presentation. World Health Organization has been a very strong partner of the Perinatal Society of Sri Lanka. You have been helping us in many of our activities. So I must thank the World Health Organization and Dr. Pense for the support you have extended all the time. And now I would like to sort of, just a small token of appreciation for Dr. Pense.
Ladies and gentlemen, next we have the most important event of the day, the keynote speech. And it is again on a very timely topic, one country, one nation, one health. To chair this session, let me cordially invite Dr. Kaushala Kasturiarachi, the President of the Perinatal Society of Sri Lanka, and Dr. Suranta Pereira, the Congress Chair, to please come on stage.
The event of the day, the keynote speech. Today's the keynote speaker is Honorable Muhammad Wawis Muhammad Ali Sabri. He's the current Minister of Justice and is a member of the Parliament. Having qualified as an attorney at law, Mr. Sabri joined unofficial bar and developed a lucrative practice in civil law. In 2012, he was appointed as a President's Counsel. He served as the Sri Lanka Consul General in Jeddah, Saudi Arabia, and he has represented Sri Lanka in many international conferences. He was the Treasurer of the Bar Association of Sri Lanka and Chairman of the Junior Bar Committee of the Bar Association of Sri Lanka. So I would appreciate his presence. I welcome you warmly. And thank you very much, sir, for accepting our invitation and being with us. And now I would cordially invite you to deliver your keynote. Thank you.
The President and the other Executive Committee members of the Perinatal Society of Sri Lanka, distinguished members of the noble profession of medicine, other representatives here, ladies and gentlemen, and those who listens to me and join me online. Good morning to all of you. It is a pleasure and privilege to be addressing this group of individuals such as you as your keynote speaker at the annual Scientific Congress of the Perinatal Society. I just realized you have been here and in existence for 20 years or so as an organized body of gynecologists, the pediatricians, and the community medicine specialists. Your field in the medicine is one of the most immense importance. I also understand one with a lot of pressure to perform with very little margin for error. Being a parent myself, I too have had the highest expectation of your area of medicine, more so than professionals who have attended to me. The contribution of the medical fraternity and the healthcare worker, along with the armed forces public health inspectors, and some of the government employees who are generally termed as the first responder in fighting the present and ongoing pandemic to keep the whole country safe is unprecedented and deserves the praise and gratitude of all. Therefore, I make use of this opportunity to convey how fortunate Sri Lankans are to have a system which has remarkably faced the challenges much better than more advanced countries in the world in terms of taming the first wave and fighting the second wave, particularly taking care of those who are infected and prevent the spread thereafter. When I was invited to speak today, I was intrigued by the topic of the keynote, one country, one nation, and one health. I say intrigued because in recent times, one country, one health has usually been followed by the word one law, and to say that it has been a controversial tagline would be an understatement. Not really. No one would oppose any notion of one law, provided it has been promoted on rational, reasonable, and inclusive basis, rather than to promote a hidden agenda to advance certain sentiment which is divisive. However, replacing the words with one health gives it a distinctive interpretation, and one which gives us the opportunity to talk about critical areas that affects our everyday lives. Ladies and gentlemen, when we say one health, we are essentially speaking of uniformity in healthcare, an application as a whole around the world as much as practically possible, and a singular way of rolling out directives and procedures related to healthcare throughout the world. When it comes to this uniformity and a body that works on one health concept, no doubt the forerunner is the World Health Organization. One of the objectives of the World Health Organization is to develop and support processes for sharing information on health system responsiveness between countries and across the region. I'm sure the country representative of the WHO would agree with me on that. And this uniform policy exists in region across the world. They collaborate with different organizations all over the world, from the Center for Disease Control and Prevention in United States, the European Union CDC, the WHO operate on the basis of uniformity, certainty, transparency, and logic. And that is really the science. The benefits of this are twofold. Firstly, it inspires public confidence in health policies. And secondly, it allows the resources to be used in the best possible manner to achieve a common goal. Imagine if all the countries in the world left to find their own vaccine without having the benefit of using the ones which have been invented by advanced countries. How long we will want to wait. Over the years, Sri Lanka has worked very closely with the WHO, and this has resulted in great strides in the field of healthcare in Sri Lanka. We in Sri Lanka are proud of our achievements. We have made impressive progress in healthcare in different sectors. In 2012, life expectancy was around 76 years compared to 40 in 1930. Child mortality rate improved from 175 per thousand birth in 1930 to 17 for 1,000 deaths in 2010 according to the World Bank. I'm sorry I could not lay to the latest figures. I'm sure it would have come even further down. Many of Sri Lanka's health indicators are comparable to those found in Thailand, Malaysia, and South Korea. And these countries have income level 2 to 6 times higher than Sri Lanka, which is also according to the World Bank. Around 95% of the inpatient care and 50% of the outpatient care is provided by the public health system, while the private sector accounts for remaining 5% of the inpatient care and 50% respectively, according to the World Bank data once again. It is evident, despite Sri Lanka not being first off the blocks from an economic standpoint, it has created and developed a public healthcare system envied by some of the wealthiest countries. In an era where politicians in wealthier states argue and debate about cutting government health benefits to public and promoting private insurance scheme, Sri Lanka has kept its heads up high and insisted on the public right to universal health care. To add to this, in recent time we have almost eradicated malaria. Our approach to dengue and its treatment are world-class, and world is learning from us. This is no accident. It is results of hard work, sweat and design. Our free education system has created top-class healthcare professionals and first responders, including the doctors, and I believe over 90% of the doctors in Sri Lanka studied at government universities. I also firmly believe our society, which is greatly influenced by Buddhism, and the values inculcated in the society through the philosophy of Buddhism, such as Karuna, Metta, Mudita and Upeksha, has a great role to play in rolling out empathy and compassion together with values which inculcated in our society, as often referred to as Arogya Paramalabha, that is, health is wealth. I've been following with keen interest and amazement the manner in which some members of your profession have been given leadership in transforming our public sector institution to different level, championing the cause for innovation, modernization and betterment of the society. For instance, the Castle Street Hospital for Women in Sri Lanka is the first documented case of 5 years application to a government hospital in a low or middle income country. It has also won numerous productivity awards. The Ampara General Hospital in Sri Lanka was awarded the best hospital in the world from Arizona Institute for Health and Productivity Management in USA. These are instances of these hospitals competing with the private sector and winning. What is interesting about this is that the private sector is driven towards improvement to a large extent due to competition and financial gain, whereas the state sector does not have the level of financial intensity for its key persons. I hope that members of my profession, the legal fraternity and the stakeholders take a leak out of your book and take the challenge to live up to the expectation and roll out a more effective and efficacious system for the administration of justice, which is also could be comparable with advanced jurisdiction, just as much as yours is comparable with the countries with even better economic indicators. Sadly, the present indicators, such as being ranked 161 out of 180 countries in time taken to enforce a contract, and being ranked 99 in the Ease of Doing Business Index, are not something to be proud of. Ladies and gentlemen, even though the health sector has a long way to go, some of the achievements and milestones it has reached are impressive. How then did this happen? If you were to look at the cases of success, you will always find that in addition to the status quo, it was driven by a passionate individual or a group who went beyond the call or duty, beyond what was expected to achieve these astonishing results. Most people assume big changes need a large coordinated effort with massive resources. Yet, you will find sometime even one person with steel will and drive can champion unprecedented challenges and changes and improvement. In the last few months, I have come across few of these instances. During the start of the COVID-19 pandemic, the process of a collection of prescription medicine in the hospital in Kandy was following the standard process. This would frequently result in patients spending hours for each visit to collect their medicine. There was not state intervention. Yet, 2 doctors created a system where time slots were reserved online to collect the medicine at the given time slot. The amount of good this did was immeasurable. This was not a project funded or even proposed by the government. It was a case of those doctors going over and above for public service. Imagine 1.8 million strong Sri Lankan public sector take a leaf out of this work and work hard as much of those champions have done. What would have been the plight of this nation? We would be and we could be world beaters. However, for this level of success to continue and to thrive, it must be predictable, fair and unbiased. It must always have a public support. Public support, however, will only come if the system is inclusive. We are in the middle of a more vicious second wave of the COVID pandemic. However, it is in times of crisis such as this that we test the real character of a society and its inclusiveness. While all sectors are working round the clock and leading from the front, some of the decisions made by certain quarters need to be looked at whether one health policy had been applied in its true sense or has it been misunderstood, to say the least. For instance, I will read from the WHO 4th of September guideline for safety management of dead body in the context of COVID-19. This is what I quote. There is a common assumption that the people who died of a communicable disease should be cremated to prevent the spread of that disease. However, there is lack of evidence to support this. Cremation is a matter of cultural choice and available resources. The dignity of the dead, their cultural and religious traditions, and their families must be respected throughout. All measures should respect the dignity of the dead persons who had died of COVID-19. These guidelines are followed to the letter in over 194 countries, which include the CDC in USA, CDC in the European Union. Professor Malik Peris, the world-renowned pathologist and virologist, chair of the Professor of Microbiology at the Tam Van Chinh University of Medical Science at the University of Hong Kong, stated that the claim that the burial of dead bodies of COVID-19 victims could lead to spread of coronavirus is non-scientific. I quote from him. The answer is simple. Viruses can only replicate in living cells, unlike certain bacteria like Ebola. Viruses by definition require living cells to replicate. Once a person had died and the cells in his body have died, the virus will die. Then, of course, I am familiar with the business of burial. So let me be clear, I am quite happy to be cremated with or without COVID, but to imagine first and foremost the scientific evidence in terms of infectiousness at the time of death, the fact that the virus cannot survive after the death, and then if you wrap the body in some impermeable wrapping, I understand people are also talking about putting some chemical in and bury the body 6 feet underground, unless you bury the body right into the running water. Even if there is any residual infections, virus that has to filter through many, many feet of soil and get into the water and survive in the water. To be honest, to be frank, this is complete non-scientific argument. And indeed, this is why WHO and many countries in the world have no problem with this, unquote, from Professor Malik Peris. In the light of that, how do we, this country, come to terms with the fact that we are forcefully cremating bodies? I will leave it to you and to come to your own conclusion as to whether it is logical, scientific, inclusive for Sri Lanka to take this stance. Should it be policy here when the rest of the world have accepted science? It is our approach to this issue compatible with One Health policy. We have achieved so much over the centuries through science. Man has progressed in so many ways due to advance in science. Yet, science has not always been inclusive. Much of history is prepared with stories of scientific advances and its benefits being available to a privileged few. In the modern world, however, we must accept that science and its benefit can no longer be exclusive. The fruits of its labor must be available to all in society, regardless of social status, religion, ethnicity, or belief system. Similar to the field of science and health, the law too has been an essential need to be inclusive. A common misconception of the law is that it equates to justice. When we say rule of law, it essentially meant that the society is governed by the law and not according to the personal whims and fancies of a ruler. It therefore easy to be mistakenly draw a parallel between the law and justice. After all, it is the law is applied properly. Does that not mean the justice is served? The reality, however, as history would attest, is very far removed from this ideal. Time and time again, the law has been used to serve the interest of one group to detriment and sometimes horrifying destruction to the other. When studying law, the subject of jurisprudence famously covers the reasoning behind the persecution of the Jews in Nazi Germany as it presents an interest in dilemma. Much of the atrocities that were carried out were actually legal as per the law of the country. They were passed by the legislature, and essentially anyone engaged in the persecution of the Jews was actually carrying out a lawful act under the laws of the land. Yet to argue that the rule of law existed in Nazi Germany is essentially justify the atrocities on the basis of the law that was followed. Even apartheid in South Africa was legal. It was a part and parcel of the law. It was used to oppress, in that instant, the majority population of that country, 90%. Slavery was legal in United States till 1965. And even after slavery was abolished, America transitioned to segregation, which plagued the country till 1964, when President Lyndon Johnson signed the Civil Rights Act. Here in our own country, during the colonial time, any act which was carried out to bring freedom to our own nation and to strive for the freedom of our people was termed as sedition and treason, which begs the question, what exactly should the law be in a democratic society? Shouldn't it be, by very definition of democracy, reflects what the majority voted for? You can argue that the reaction to any law, positive or negative, will always be subjective, and there will always be someone who is not happy and someone who is. If the majority voted in a government, then the law should be with what it suits them. As logical as this may sound in theory, in practice, this very argument is what have been used to advance divisive agendas. I am sure we can for one moment put aside our religious and ethnic colored glasses and agree that in all the example I just gave, just because something was legal, it doesn't necessarily mean that it was moral or humane. The law should not be a tool in the hands of ones wielding power to oppress the weak or those who are different. It should not be tyrannical or essentially vengeful. It should be inclusive, moral, humane, and fair. The law needs to protect everyone, regardless of whether they voted for the government or not. A mandate by the majority isn't a license to attack the oppressed who aren't. Joe Biden, in his speech on the 7th November said, "I will now be the president of America. I will work as hard as for those who didn't vote for me, as those who did." This is true meaning of democracy. You are not only the leader of those who voted for you, you also lead those who didn't. You need to be the champion of all groups, not only your favorite. This is the same sentiments expressed by our own Honorable His Lordship, His Excellency, the President Gotabaya Rajapaksa at the historic Ruam Valley Saya during his inaugural speech, where he says, irrespective of whether you voted or not, I will be the president for the whole of Sri Lanka, not just for whom voted for me. The goal of any government shouldn't be to assimilate the history, culture, and identity into a singular character. There should not be fear or hate of diversity, different identities, traditions, and culture within a state which need to be celebrated. They should not be feared, hated, or ridiculed. In other words, there should be unity in diversity. Law should not be a license to suppress culture. Article 9 of our Constitution speaks fostering and promoting the Buddhism. The Article 10 speaks of freedom of thought, conscience, and religion. Article 12 of our Constitution states that everyone is equal before law, and it also entitled to the equal protection of the law. It also states that a citizen shall not be discriminated against on the basis of race, religion, language, caste, sex, political opinion, place of birth, or any one of such ground. Clearly, the foundation upon which the entire state of Sri Lanka is governed by an equality clause while respecting diversity in our society. Yet, with all inclusive laws, the practical application would account for naught without a humane approach. We need empathy, compassion, and ability to relate to someone else's misery. Sri Lanka is famous for its great Buddhist philosophy, and it is what we exported for a long time. The innate beauty and goodness of the Buddhist philosophy is without comparison. The historic speech our former President Jaya Jayawardena given in San Francisco in support of Japan, using the famous words of wisdom from Lord Buddha, Vaireen vaire no sanside, avaireen ma vaire sansite. That is to say, hatred does not cease from hatred, but love changed the course of Japan and made it what it is today. Sri Lanka is known for this empathy and compassion and should continue to be known for that. Lord Buddha preached, Sielu satveo nidukvetva, nirogi vetva, and dukin midetva. That's the type of compassion, the culture of mercy we must always strive to achieve. It is our legacy, and we must always retain this respected and loved characteristics. Ladies and gentlemen, and dear professionals, when speaking of empathy and compassion, a sector of our society that I believe deserves it are those who are addicted to drugs. The traditional take on this is that drug addicts are criminal and should be treated as such with incarceration. Our prisoners are full of persons who have been looked up for using drugs. I don't agree with this view. I see a difference between drug traffickers, peddlers, and addicts. What an addict is going through does not need punishment. He needs our help. He needs rehabilitation and guidance and get his life back. It is, in my opinion, a socio-medical issue which needs to be looked at from the view of medicine and science and not as a problem to be solved with criminal justice system. It requires an effort from all of us, and especially the medical field, to find long-lasting solution for this issue, to get them out of addiction and to rehabilitate them so that they can integrate to the society and be a partner in progress. Another area which routinely gets ignored in the discussion about health is a mental health. I believe this is typical Asian issue where it's seen as an embarrassment to admit that you have been in any form of mental issue or episode. In Sri Lankan society, a mental case is used as a derogatory insult, and no one seems to understand the gravity of being so insensitive towards a person with a medical issue. People just don't want to seek help for fear of being ostracized. This has sadly split over into a situation where a person just don't respect the importance of another's mental well-being. Even Article 12, Covenant of Economic, Social and Cultural and Rights, CESCR, speaks of the right of everyone to the enjoyment of highest attainable standard of physical and mental health. This lack of ability to relate to someone else's plight, the population's need for shock value and negative news, and the ability to go viral on social media has created the perfect storm. We are all aware of the despicable manner in which the media hounded suspected COVID-19 positive cases. The image of a person being hounded up into vehicles while cameras rolled were being widely circulated, almost as if being COVID positive made you guilty of some grand crime. This issue of lack of empathy and violation of privacy is closely connected to social media hijacking the people's life. This is something very wrong about the way patients were shown and their privacy and mental well-being violated. Yet, despite so much of happening, the outcry from the professionals is very soft. Professionals and organizations can't shy away from their responsibilities in this trying time. As professionals, we have a duty toward the public. The duty is not just a passive one, where the medical or legal professionals should stand back and help when they ask. It is a positive one, where they are under a duty to actively fix the misconception and issue within their spheres of expertise and come forward as champions when their field is used as a tool to oppress and attack a vulnerable group in the society. Even in the Vandapeti case incident, there was a lacuna in the amount of those who came forward with the facts. When one member of your own profession is accused of forced sterilization. It is important to come out and explain whether or not it was logically possible. I am aware that one of you did somehow come out and take a strong stand publicly, and that is admirable and what should be strived for. When you are in a position of privilege, you have a duty to use it for the common good. When professionals take a back stage and let politicians and people with hidden agendas and such prejudices drive a debate towards with no intellectual discourse based on actual experts in the field, the overpowering voice of those politicians and persons fueling a divisive, damaging and oppressive campaign is heard larger. As the saying goes, Deva Duteo Payano Gahana Tana, Modeo Karanam Gahana. So it has to be understood in that context. This is the challenge for the future. The act in line with the collective, moral and empathetic conscience to speak out when something is wrong and to give leadership to the society which is inclusive, fair, equitable and rational. We as professionals have a duty to make our voice heard when an injustice is committed, to stand with the oppressed, to defend what is right and stop the discrimination of our professions by those with their own agenda. We must not allow hegemony take over the default basis of governance. People need to believe in being part of a country that treats them with dignity and respect regardless of what society group they fall into. We can't let our society discern into a social food chain where the powerful always overpowers the weak. Society has a moral obligation and duty to protect those who are marginalized, whether they are women, children, targets of gender-based discrimination, those who have different sexual orientation, or those who have mental health challenges. We need to stand with them, support them and guide them, and create a culture in which every Sri Lankan feels they are part of a larger society and inclusive. Different identities must be cherished and celebrated while assuring the safety and protection for everyone equally. Hoping things will get better with no positive action is a recipe for disaster. Ladies and gentlemen, many of us, particularly the professionals, have been watching with concern some sections of the media and certain elements of society, social media, driving an agenda which is influenced by prejudice against sections of our society in time to time without actual, rational, logical reasoning and the kind of consequences which may eventually extract a heavy cost on our society. Though we may feel comfortable momentarily by the fact that those are not directed at us, we cannot afford to be complacent and ignorant what is happening. Let me just quote one of my all-time favorite quotes, which is from Martin Niemöller, where he says, "First they came for the communists and I did not speak out because I was not a communist. Then they came for the socialists, I did not speak out because I was not a socialist. Then they came for the trade unionists, I did not speak out because I am not a trade unionist. Then they came for the Jews and I did not speak out because I was not a Jew. Then they came for me, then there was no one left to speak out for me." So it is time for the influential members of our society, such as you and members of my own profession, who are educated, to take a leap to shape the future of our country and destiny of our nation. We must make it live up to the true ideals that have influenced this country, brought up by all great religion and foremostly by the Buddhism. In the timeless words of Charles de Gaulle, politics is too serious a matter to be left to the politicians alone. Thank you very much.
Thank you, sir. We gave a topic, a little challenging one. One health, one nation, one country. It is correct either way. And he showed his oratory skills and made the task very simple. We extend our gratitude and we are privileged to listen to your excellent speech. With his permission, we usually keynote speaker, we do not allow audience to ask any questions, but we will allow limited questions, probably 2 or 3. It has to be specific, it has to be short, and sir can briefly answer that. So I want Dr. Chitramali De Silva, Director of Family Health Bureau, to ask one question. She wanted to ask one or two, but make it a one question.
Thank you, Suranta, and thank you, sir, for giving this opportunity. I think when we look at the maternal and child health program, we are working towards healthy mothers and healthy newborns. So in that case, we see many challenges to achieve this, although we have one nation and maybe stipulated laws which are imposed by the country. One issue that we raise is the teenage pregnancies. So we see the teenage pregnancies are high among some ethnic groups, maybe because of the different laws of marriages in different communities. So I think in one law, whether we can go for such a decision so that we will have less teenage pregnancies and the outcome of the mothers and the newborns will be satisfactory, and also we will be able to reduce our maternal and the newborn mortality further. Thank you.
Thank you very much. I think that's the approach should be. When you look at something on the scientific basis, is something on the place, on the ground is not helping that, in order to improve that, that should be the approach. So I agree with you. Teenage pregnancies should be some or other avoided. So in that sense, personally speaking for myself, I'm working on that. We need to equate the law where marriage age should be 18 across all the ethnicities. If we, that is because, not because anything else, because science, because everyone should respect science and respect the progress that we have made on that. So to that extent, yes. That is exactly, while we preserve the differences, how we strive hard for uniformity. To that extent, I think some of those personal laws need to be amended. But in the meantime, we also must understand that is, the law itself provide for that, and that should be avoided. But teenage pregnancies are happening in other, even with the gender law also. So that's also a matter of awareness also, education also. So let's strive hard on that, and wherever you need support on logical basis, we should come and support that. I'm sure we will do that.
That's an excellent answer. I think mixture of, when we look at this perspective, mixture of science and then the beliefs, culture, political dimensions, everything have to be taken into account. So the second question, I invite Professor Hemantha Senanayaka sir to ask the.
I wasn't expecting this, but anyway, thanks very much for coming here and then for taking the questions as well. It's not very often that we get a chance to talk to a minister and a senior minister, or influential minister. I really would like to, one of the things that I have been worried about all along is that how opinion is being bulldozed by media, and also some of the things that are happening in Parliament. And I really think that it's not a question. I really think that's something we need to address. Because, you know, I don't think we have such a vibrant public opinion in Sri Lanka. Partly because anybody who, I have personal experience with that, anybody who comes and tells something opposite, and this is what is happening, you alluded to the burial issue, which is completely against all science. And if somebody is trying to come out and say something opposite to what is the mainstream, and that person is really, you know, at risk. So I think this is something you need to address as a government, the protection for people who are, not breaking the law, but expressing their own views, and sometimes for good reason, and sometimes for a major benefit to the country. As you are seeing, we are alienating one group of people at the moment, and we are seeing people being radicalized, and that's really harmful. And I would really like your response to that, and maybe see what you can do about it.
Precisely, Professor, thank you very much for raising that. I mean, we should promote diversity and difference of view. We can't be saying that everyone must hold the same view. That won't happen. That is why freedom of expression is guaranteed by our Constitution. Article 14(1) says that people should have the freedom of expression. Of course, subject to the national security and some laws. As long as it's a different opinion, you can't suppress that. But you are correct. The manner in which some section of the media is handling, that's what I want to read that. It's nothing new. This has happened over and over again, and it has led to destruction of societies. And if you look at what happened during the, just before the Second World War in Germany, is like that. For everything they found someone responsible, not taking responsibility their own. So this need to be addressed. I agree with that. And suppressing dissent is not a good thing to do. If you learn from our past, I'll just give a couple of examples. After the 1977 elections, the leader of opposition was Ampapille Amirthalinga, and TULF, now it's equal to TNA, had 17 members in the parliament. For whatever the reason, they were forced out of the parliament. So, a comparatively moderate voice or democratic voice was silenced. But did the Tamils stay away from other things? What happened? They were forced to go and take refuge with LTT and Prabhakaran. That's a dangerous thing. In 1983, when the July, the pogrom happened, everyone knows then government was involved in that. But when they went and proscribed the Vasudeva Nanayakara's NSSP, the Communist Party, which are fundamentally against racism, and JVP, which was coming into the mainstream politics, which they got 300,000 votes, and they were happy to be part of the integral part of the democratic society. They were driven out of politics. They were forced to go underground, and then we saw the consequences in 6 to 7 years to come. It's a dangerous thing. So it's happening to some other community today. Moderate voices have been just marginalized. The moment to come out and say something which is rational, reasonable, on science, it's targeted and say that extremists. So I'm worried, to be honest. Then what happens? Sections of these people could go and take refuge on some extremists from the other side. So extremism is not an answer. We need to find middle ground. We need to find middle ground. Middle ground is an inclusiveness. In that, approach should be to get all of them on board, is from that professor who asked the first question, based on science, rational, logical thinking. I'm sure our media will also learn the role of the media and the public and the government should to unite the people, not to find scapegoat for different failures. So it's important that we look at this and as a society try to evolve as inclusive as much as possible so that we create a truly multicultural, multilinguistic, multi-faith country where all feel dignified. So that's the recipe for real advancement and achieve the true potential of our nation. Otherwise, we'll be going back to the history once again and again, every 20 years, which has happened from ever since the achieving our freedom.
Thank you. All the activities of our society and the deliberations of the Scientific Congress are being supported by UNA agencies, and WHO we know at the forefront. So this invitation goes to Dr. Razia Pense, country rep for WHO, to make a comment or ask a question.
Thank you, Professor Suranta. That was a surprise. I would just like to commend the Honorable Minister for a very eloquent and elucidative speech, picking on important issues where health intersects with the social cohesion as well as the general development of the country. And I was really heartened by your stand taken in terms of addressing drug users, that really the country needs to address this, that drug use is actually, it's a problem, it's a medical problem. You're addicted and you need to find a way out of addiction. Incarceration is not the answer. And I think so, under your leadership with the Ministry of Justice, if we can move this agenda, because this would be very important, because unfortunately, drug users are young people, generally, largely, and in terms of having more cohesive, equitable, compassionate societies, this is one thing that we would really like, that we could work together with yourselves and your offices to find a solution. The extent of the problem is large, but again, equating drug users with traffickers is a huge mistake, and that really needs to be addressed. Also addressing the issue of health in prisons. And in the context of COVID-19, it has been brought to the fore that overcrowding is actually fueling the pandemic, and we saw clusters periodically that have emerged, some small, some large. But that's something that we would really want to work together with. And we do have guidance, but it needs to be translated into action. So thank you very much, Honorable Minister.
Yeah, thanks for that comment. I think final question will be asked by Professor Dulani Gunasekara, Professor of Chair, Pediatrics, Sri Jadranpur University.
Thank you very much, sir, for that very thought-provoking talk from you. As a pediatrician, and I think as pediatricians and obstetricians as a whole, one problem which is at the core of our hearts is termination of pregnancy. I know this particular topic transcends many religions and cultures, but as far as the mother's health is concerned, both physically and emotionally and mentally, I think there is a real problem there, especially when things like fatal, congenital anomalies which are non-sustainable, what we call lethal anomalies. Once the mother knows, now ultrasound is very widespread. Almost every mother has an ultrasound during pregnancy. And if there are lethal malformations, they do get to know very early in pregnancy that this child is not going to survive. Either they will die in utero or soon after birth, and there is absolutely no hope. So in such situations in Sri Lanka, still we don't have any recourse for that poor mother. She has to go through that pregnancy and then deliver that child, which may be already dead or will die soon. So I think it is a great, it will be really good if we can address that issue, although I know there are multiple problems involving cultural and religious issues when it comes to this, at least to save the mother's mental and physical well-being.
Yeah, thank you, Professor. Before I think that's an area we need to discuss. We can't shy away from these things. And particularly, I have been voicing my opinion even on this child abuse and all those things. And you can't be just shy away from the reality. I am of the opinion that awareness, those decisions have to be made on science and logic. So if necessary, that child abuse, the sex education to be introduced to the schools, I'm sure you will agree that it has to be done, so that we need to look at that. I think at least we are starting a dialogue on that. It's a good thing, and I'm sure what you all are also starting. I know everything can't be achieved overnight, but at least you are putting that into the forefront and starting a discussion on that, and will progress towards that. And when it comes to the WHO country director's concern, I'm thankful for the offer of help. I think that is very needed. And we have, as a government, last week also we had a discussion with His Excellency the President, looking at the substance abuse as overall, rather than transforming from one quarter to the other. What happens is now in the society there are drug addicts. Police want to remove them and put it into the prison. In the prisons are overcrowded and the problem is transformed to the prison. Then it is to the court. Then it is to the government analyst. Thereafter it is to the someone else. So we can't be handling questions like that. We are looking at from end-to-end solution in that. In that, one most important thing is to identify the differences between the traffickers and smugglers and the people who have been addicted to drugs. They are in fact victims. They need our help. So we are looking at rehabilitation instead of incarceration. So that is where your support is necessary. I'm sure we will meet one of these days together with the ICCRC and been very, very vocal and helpful in prison reforms and all those things. So your expertise in designing a mechanism which would help them for reforms and rehabilitation is very much welcome. I'm thankful for that suggestion. I'm sure my ministry will get in touch with you. Thank you.
Thank you very much. We are grateful for your presence here today and all the support extended for our society. One small request, I think we as a society, Dr. Kaushala and I and some of the members of this audience would like to meet you in a different setting to discuss some of the issues raised here. I hope you will grant an appointment for this in future. While appreciating all the support, I invite Dr. Kaushala Kasturarachi, President, Perinatal Society of Sri Lanka, to present a token of appreciation on behalf of the society. Thank you very much.
On to a very important event, which is Professor Indraji Amarasinghe oration on obstetric transition, the pathway towards ending preventable maternal deaths. Thank you very much. Please be seated. I now invite Dr. Kaushala Kasturarachi to read out the citation of the orator for today, Professor João Paulo Sousa, Professor of Public Health, University of Sao Paulo, Brazil.
Professor João Paulo Dias de Sousa graduated from the Faculty of Medicine of Ribeirão Preto of the University of Sao Paulo in 1998. He completed his medical residency in 2002 in obstetrics and gynecology and intensive care medicine from the Hospital das Clínicas. Between 2003 and 2008, he was an assistant physician at the Center for Integral Attention to Women's Health at UNICAM and completed a master's and a doctorate at the Faculty of Medical Sciences at UNICAM in the area of maternal and perinatal health epidemiology. Between 2008 and 2013, and later between 2016 and 2017, he served as a doctor and a researcher at the World Health Organization, Geneva. In 2014, he joined the faculty of the University of Sao Paulo, and after obtaining the title of professor from the same university same year, He started a series of studies focused on health promotion practices. He became a full professor in 2016 and as a professor of public health, working in the area of health promotion and disease prevention. He involved in the academic coordination of the family health unit linked to the Department of Social Medicine. Professor Sousa's current research lines and interests are eco-socialism and health disease process, promotion of women's health and sustainability. He is currently spearheading many projects including the Perinatal Bereavement Project, development and evaluation of supportive guidelines for families experiencing stillbirths and neonatal deaths in southeast Brazil, better outcomes on labor difficulty, maternal morbidity and near misses, Champion, a phase 3 randomized double-blind active controlled multinational non-inferiority trial. And Professor has many publications which are very frequently cited. Somehow, I would like to invite Professor Sousa to deliver his oration virtually. Professor Indrajit Amarasinghe oration. Thank you.
Good morning. My name is João Paulo Souza, and I'm a professor of public health at the University of São Paulo in Brazil. I'm deeply honored to deliver this presentation to you all, and I would like to thank the Perinatal Society of Sri Lanka for this kind invitation. I also would like to greet my colleagues and friends from Sri Lanka and tell that I'm going to make this presentation on the obstetric transition. The obstetric transition is a concept that we came about some years ago to try and understand the development of maternal mortality as an indicator. So first of all, for us to think of maternal mortality from the epidemiological point of view, we would think that maternal mortality is a health indicator, but also an indicator of gender equality, an indicator of social development. And for these reasons, the maternal mortality has become one of the indicators of the Sustainable Development Goals. And this is so because maternal mortality has a complex multifactorial causal pathway. So it is biological. It also depends on the organization and performance of the health system. It has essentially social determinants and depends on the cultural context. So in order to affect a sustainable change in maternal mortality, one needs to address several of these root causes. So one needs to be to address the biological causes, also improve the organization and performance of the health system, but also address the social determinants and the cultural context. For many years, we have been observing this secular trend towards reduction of maternal mortality. We estimate that the natural maternal mortality rate is around 3,000 maternal deaths per 100,000 live births or more. And the optimum maternal mortality rate, and optimum means when all the avoidable deaths have been indeed avoided, we would have a maternal mortality rate ratio of less than 5 maternal deaths per 100,000 live births. And the journey between these 2 points, we call them the obstetric transition. My presentation will cover 3 points. The origins of the concept, the concept in itself, and a brief application of this concept to Sri Lanka. Our story starts about 4 million years ago, 3.9 million years ago, with the Australopithecus. And this is an important time in the evolution of for the evolution of our species, because is when this Australopithecus became bipedal, so start to walk over 2 feet. And this is important. The bipedalism is important to our evolution because by becoming bipedal, um, those first hominids, they were able to become more effective predators. They were able to hunt more effectively. And that gave them access to proteins and other nutrients, which created the conditions for the brain development. As you can see in this graphic, what from the very beginning, when there were the Australopithecus, the first Australopithecus, and then the Homo habilis, Homo erectus, Homo sapiens, and then now the Homo sapiens sapiens, that our species, there was a trend towards an increase in the brain size. And with that, with the capacity of complex thinking, and also in order to develop as a society. So bipedalism was essential for us to become better predators. By becoming better predators, we had access to nutrients, and the access to nutrients created the conditions for brain development, which enable us to become sapiens. In this image, we can see different apes or different hominids, including the humans. And I bring this because these are the bipedal. Some of them, they're semi-bipedal, and we are the more effective bipedal hominids. And the fact that we became bipedal made us born to run. We're essentially an species that is very effective in running and running long distances. And it is because we can run long distances that we can effectively hunt, or we can fight against animals that are much stronger than us. Because we, in the past, the modality of hunting that was practiced before there were effective tools or even strategies for hunting was chase the animal until it really is unable to run longer, and then it was hunt. But this capacity of running long made the pelvis narrow. And if we look at in a different slide here, what we see is that creates a tension between bipedalism and encephalization, because for the species, in order to get it stable, it needs to get a narrow pelvis. And by getting more access to nutrients, the brain size increased, so created this tension between pelvis and the brain size of the fetus. When we compare in this graph different species and the relative dimension of the fetus and the pelvic inlet, what we can see here in the external square here is the size of the maternal pelvic inlet, while in the black box, what we see is the size of uh, the, the fetal head. And in different species, what we see is that the fetal head is much smaller than the pelvic inlet, while in the Homo sapiens, our species, there is one dimension that where the um, fetal's head is larger than the pelvic inlet, which creates the need of rotation. So we are one of the very few species that where there is rotation, and that affects the length of labor and also complicates to a certain extent childbirth when we compare in these different species. That also contributes to the variability around labor and childbirth that we see in our species. So there are labors that are fast, others that are very slow. And it's important for us to remember that labor and childbirth are physiological processes mediated by hormones. And this evolutionary competition between bipedalism and encephalization led to the current biology of human parturition. And why I'm bringing these issues for us and just for us to think. In the very past, when there was stress and fear, there is the release of adrenaline and other catecholamines. There is the disruption in oxytocin production during labor, which makes labor slow or stop labor and would enable that woman to move to a safer and more protected place for birth. That's kind of the physiological process that relates stress and fear levels with the progression of labor. So let's give an example. For instance, if there were a woman that was in nature and she was in labor, then she perceives, for instance, some danger. That would release adrenaline and other catecholamines that would slow eventually labor and enable that woman to move to a safer and more protected place for birth. But there is a potential problem in that is, if the distress is very severe, then there could be a blood diversion from the abdomen and disruption in the placenta blood flow, and that could contribute to fetal distress. So if we bring now this physiology to our reality, whenever there is stress and fear during labor, there is release of adrenaline and other catecholamines, and that could contribute to slowing down labor and producing fetal distress, and that would then lead to interventions during labor, right? So there are some interventions actually now thinking of how we provide care to women that would that design the birth or delivery room in order to maximize reduction of stress and then enable a more natural labor. So we would then promote the release of melatonin, and that would increase the response to oxytocin. There's been a number of papers that have been building on the static nature of the birthing room, or even some ways to try to induce a calming and relaxing environment in order to produce less stress, more melatonin, and then less interventions during labor. So here you can see some different birthing rooms and the lighting, for instance. And there are some of them that produce less light, or light that is affect the production of melatonin. And with that, we would have less disruption of the birthing or labor and then childbirth. But beyond the biology of labor, it is very important for us to consider the care process. And there is a number of studies that relate, and there was created this hypothesis of the pressure tank, where the stress of women and also health providers could enable the occurrence of mistreatment of women during labor and childbirth. But going beyond even mistreatment of women, what we could see as well here in this graph is that as we increase the number of women being taken care by the unit, there is a correlation with the number of interventions, in this case, cesarean delivery or episiotomy, or even artificial rupture of membranes and forceps and taco. It seems that as the workload increases, the health professionals, they feel the need to actually expedite labor and then start to do interventions. So when we think of the variability around labor and childbirth, what we need to think as well is that while labor and childbirth have a biological basis that was built throughout human evolution, it is also a social and cultural phenomenon influenced by the healthcare process. So the birth environment and social cultural factors, they affect the endocrinology of birth and may contribute to increased risk of adverse risk birth outcomes. So that is kind of the context where it's the obstetric transition is developing. So it's a multifactorial process where there is culture, where there is society, where there is social determinants, there is as well the human biology, and also the care process. All of these things combined, they contribute to the progression of labor and childbirth and the occurrence of complications as well, and in a more thorough analysis that could also contribute to maternal deaths. So that's kind of the background that we are analyzing. So let's now talk a little bit more of the transition. So as I mentioned, there is this trend towards reduction of maternal mortality. This has been seen in different countries, different regions. Over the years, there is this reduction of maternal mortality. But how should we understand and deal with this variability? And for doing that, we went back to some epidemiological principles, particularly different models of transition. So here I'm going to talk about the three of them. So there is this 1929 model of demographic transition, where there is this trend from moving from high mortality and high fertility to low mortality and low fertility. Then there is this transition, the epidemiological transition, that moves from the high prevalence of communicable diseases to a high prevalence of non-communicable diseases. And we call that the epidemiological transition. And the last transition that we have seen or has been described before, the obstetric transition, is the nutritional transition. When we are moving away from the traditional diets that are generally rich in fibers and cereals, and progressively adopt a modern Western diets that tend to be high density of calories and animal fat, which is in the root cause of the obesity epidemic that is happening across the world. So based on these three models and also observing the pattern of change in maternal mortality, we start to conceptualize the obstetric transition. So demographic, epidemiological, nutritional transitions together with other various socioeconomic, cultural aspects. For instance, the globalization, urbanization, aging of maternal population, led us to investigate and describe this phenomenon that we call the obstetric transition. And we did that by reviewing country and maternal mortality, fertility rates, and the cause of maternal deaths. So we proposed some years ago that there is this transition taking place in obstetrics and in the maternal population. So the trend that moves from high mortality to low mortality, from high fertility to low fertility, from direct causes to indirect causes. And we are also moving away from the natural history of birth and moving towards medicalization with progressive use of interventions during labor and childbirth. And also there is this process of aging of the maternal population. As part of this process and looking also to the countries, we propose 5 stages to the obstetric transition. So the first stage is when we have the maternal mortality ratio more than 1,000 per 100,000 live births. Then we have the stage 2, where the maternal mortality ranges from 300 to 1999 per 100,000 live births. Then we have the stage 3 from 299 to 50 per 100,000 live births, and stage 4 from less than 50 maternal mortality deaths per 100,000. And then we would have this hypothetical stage, the stage 4, where all avoidable deaths are indeed avoidable. And now we think that this is possibly less than 5 deaths per 100,000 live births, but that we don't know yet, because it's still in countries where we have less than 10 and or even less than 5, although this is very, very rare. People, when they go after those deaths, they still find avoidability factors. So we actually don't know what is the level where all avoidable deaths would be indeed avoided. So I will describe briefly the stages, and I'll start by stage 1. Stage 1 is a stage where, for instance, in 2010, 10 years ago, there were 2 countries still with more than 1,000 deaths per 100,000. It were Chad and Somalia. It's a very high mortality, high fertility, direct causes plus communicable diseases. And the main issue here is that we are very, very close to the natural history of pregnancy and childbirth for most women. And in those situations, we really need to start building infrastructure and then also introduce some cultural changes, even in order to get and to be able to bring women closer to the health system and then provide some care to those women. In stage 2, which is also a level of very high maternal mortality, from 300 to about 1,000 per 100,000 live births. And that would comprise a large number of African countries, for instance, where there is still high mortality, high fertility, and these combinations of direct cause plus communicable diseases, and where the main issue remains is access to care. And we have this issue of lacking basic infrastructure like roads, transportation, health facilities, but also education, particularly female literacy. There are issues of very weak health systems. There is a lack of skilled birth attendants, and we lack a shortage of essential interventions. And in those contexts, the poor quality of care is actually a deterrent of women. So women, they are afraid to come into the health system. So they prefer to be close to the natural history instead of coming to the health system. So that is a complex stage where we have actually to really create the basis for an effective care to be delivered, and also promote this cultural change where the health system they become perceived as a collaborator, not a risk factor, if you like. And here, in this stage, and on top of creating the basic infrastructure, the main focus has to do with the primary prevention. So we are talking about family planning, we are talking about iron supplementation, we are talking about insecticide-treated nets, we're talking about removing barriers from accessing the health system. And that should be the main focus. We have to really to invest on primary prevention and as much as possible reduce or mitigate complications and if they occur. Stage 3 is what I call it's a really where the things change and change quickly. And it goes from a maternal mortality rate ratio from 50 to 299 per 100,000 live births. And here, examples could be given as India and Guatemala, where mortality is still high, the fertility is variable. There is this combination or double burden between direct and indirect causes. The main issue here is still a mixed state. There are issues of access to the health system, but also issues related to quality of the system. And this is something that we need to consider as something important, because we need to create and improve the basic infrastructure. Poor quality of care is still a problem, but also we have something, and we have things to really to work and develop. Here, the focus is complex because we need to still invest in primary prevention, but also be able to invest in secondary and tertiary prevention. So we still have to look at family planning, iron supplementation, treated nets, removing barriers from accessing the health system, but also we need really to focus on timely and appropriate treatment of complications and disabilities. Now we are talking about the stage 4, and many countries are, or some countries, a number of countries is in this stage, and we have countries in some of them in Latin America, others in Asia, and all developed countries are in this stage. So the mortality is low or moderate. There is also a low fertility. There is a trend towards indirect causes of maternal mortality, so the non-communicable diseases, heart disease, lung diseases, and other conditions that are prevalent in those populations, they start to become more important, or they compete with the obstetric causes like hemorrhage or hypertension. The main issue here is quality of care, because it's the basis for an effective health system that has been built, at least for maternal health care. And the issue has to do with delays within the health system, and also something that starts to happen in this stage is the issue of over-medicalization. So we start to use unnecessary interventions, and those interventions, they may have complications and contribute to mortality as well. Here, the focus is improvement of quality of care and what we call the quaternary prevention. That is essentially the prevention of unnecessary interventions. And here we have for the last stage, the stage 5, which is aspirational, largely theoretical, and has to do with very low mortality, low and very low fertility, indirect causes and non-communicable diseases. They are the most prevalent condition. The main issue here is the long-term sustainability and over-medicalization, and also the sustainability and the quaternary prevention. So that remains here. So we think that the obstetric transition, the progression is not always linear. There is issue of inequity. Different countries may experience different stages coexisting in the same country. And we have really to think of the quaternary prevention in obstetrics because we need to emphasize the importance of prevention of unnecessary interventions. Unnecessary treatments increase the risk of suboptimal and poor outcomes. And here we have a number of examples of interventions that are frequently overused. C-section, episiotomy, restrictions in maternal position during labor and delivery, epidural analgesia, induction and augmentation of labor, and the overuse of laboratory and other diagnostic tests. That generated false positives and trigger interventions. In terms of overuse of medical interventions, we are seeing this cultural change among health professionals and patients or clients because surgical interventions are being perceived as safe, and there is a shift in the concept of normality. In some settings, at least, cesarean section is now the norm, becoming the most frequent mode of birth. And that's something that we still believe that may not be the best for women and babies. And there is also something for us to consider, that is the progressive loss of obstetric skills, and wonder whether this is really a dying art. Once there is the number of assisted vaginal delivery is reducing across the world, and moving directly towards cesarean section, and also the reduction of the importance of physical examination with increase of the importance of the ultrasound. So for many of us here that are dealing with the reduction of maternal mortality, this is a critical topic, that is the quality of care. This is a multidimensional concept that should be women and family centered, that has to do with the infrastructure, but also with the process of care. Something that goes beyond just coverage, but also think of proper indication, avoiding unnecessary interventions, but also the quality through that this intervention is actually delivered, and produces a positive health outcome together with satisfaction and respectful humanized care. In terms of interventions that we can do in order to promote and foster progression or accelerate progression in the obstetric transition, on top of the social determinants intervention, the cultural changes, the strengthening of the health system, and part of that actually is the audit and feedback, where we should actually use those interventions in order to really improve care. And as maternal death become less frequent, we need to develop a proxy or surrogate, for instance, with the use of proxies like the maternal near miss that are useful at the local level. And different than maternal mortality, the audit and feedback of maternal near misses could tend to be a positive entry point for behavior changes. So that's something that we should consider. And as part of the structure of audit and feedback, where we have surveillance, we could put it in the context of surveillance and response, where we take measures related to audit and feedback, and then strengthening actually local action and strengthening the health system. We need also to think of the use system thinking in order to get surveillance of the whole system, generating actionable information, and the component of response, that is the engagement of multiple components of the health system or the health service. We also need to consider the importance of co-interventions like emergency preparedness, training drills, and accountability like public dashboards and transparency portals. Well, with that revision or that review of the concept of obstetric transition, we could think of the obstetric transition in Sri Lanka and what that means. So the key indicators for the analysis of the obstetric transition in Sri Lanka are the maternal mortality ratio, which is in 2018 an impressive 32. So congratulations. It's a level that is very reduced compared to other countries. But we are also seeing an increase in the cesarean section rate that is 39, which could be a proxy for the indication of medicalization. So we are seeing that the process is actually more and more being medicalized. And also we can observe the shift in terms of causes of maternal mortality, with obstetric hemorrhage still remaining as an important cause, but the importance of the heart disease and other chronic conditions is increasing. So with these indicators, we would say that Sri Lanka is in stage 4 of the obstetric transition, where we have an issue related to the quality of care. So that is a lot has been done in order to have good quality of care. And something that we need to focus now is how to keep improving quality of care, and also how are we going to achieve sustainability in the long term of this quality that has been achieved. And also the issue of over medicalization that we start to note with the cesarean section rate. So focus in quality of care, addressing health system sustainability and possibly some issues related to equity, but also the emphasis on quaternary prevention, the prevention of unnecessary interventions. And this is my last slide. And with that, I'd like to conclude to say that we're going through the obstetric transition. The focus of the strategy for reducing maternal mortality should be modulated according to the stage of the obstetric transition. And in Sri Lanka, the main challenges would be to consolidate quality of care and the prevention of unnecessary intervention. With that, I would like to conclude my presentation and thanking you all for the audience. And also, once again, I would like to thank for this very kind invitation. I felt deeply honored by this invitation. And I hope to be able to return to Sri Lanka very soon, just after possibly the end of the pandemic. And then we can have a conversation again, maybe next year or in the next Congress of the Perinatal Society of Sri Lanka. Thank you very much for your attention. And with that, I would like to close my presentation. Thank you.
Thank you very much. Ladies and gentlemen, please rise as the ceremonial procession leaves the hall.